My name is Kelly Cox, and I'm the Senior Director of Regional Community Workshops, and I'm very proud to bring a program to your area. This is a live program which will be recorded for the future, and you'll be able to use it at your pace, get a notepad, things like that in case you miss anything. None of this would be for us unless I thank our generous sponsors. It's Amgen, Bristol Myers Squibb, GSK, Janssen, Karyopharm, Arcopedis, and Takeda Oncology. These folks help us out a lot, and with their generous donations, we're able to bring these programs to your area. And I think that it's very important that you stay on with us. The International Myeloma Foundation has been in operation for 30 years, almost 31 this November. And I want to say that we are the go-to for information while you're on your journey with myeloma. Some doctors have said some things to me, and something that always sticks out with the new myeloma patients and even current myeloma patients, that this is not a sprint, it's a marathon, it's a journey, because so much has happened. When I started 30 years ago, thalidomide was the only drug, and as you'll see some slides from our presenters, there's much better picture out there. Without further ado, I'd like to introduce our program, no, I'm sorry, go back, Amira, on how to manipulate the slide questionnaire. We need your feedback, and we need the feedback in order to bring the program back next year. There is a survey that you can click on your bottom there where it hits play, question mark. Is that a file box, Amira? File box. Our logo takes you to our website, paperclip, and the survey. Please, please, please try to fill out that survey. Amira, on that question mark, that's when the questions go in the slot. All right, then there's a question mark for your questions, and what we'll do is try to answer those after. We'll read them out and then answer them after each presentation. So the next step here, as I said, my name is Kelly Cox. I am Senior Director of Regional Community Workshops. Today, we have three of my dear friends. Dr. Craig Cole will be discussing Myeloma 101 and Frontline Therapy. He's from Michigan State University, Breslin Cancer Center, Lansing, Michigan, where I hear that it's a little hot today. Is that right, Craig?
It's beautiful so far.
Oh, well, it's hot here today, as I said.
It's hot there.
I'm sorry, I got sidetracked there. All right, we'll have a Q&A with the panel. We'll do a stretch break, and then we're going to have Dr. Hari talking about relapse therapy and clinical trials. Dr. Hari has been doing this for a couple of years, and he knows everyone that is in this world of myeloma, and we're real pleased to have him here. He's at the Medical College of Wisconsin Cancer Center in Milwaukee, Wisconsin. Dr. Hari, how's the weather there today?
It's a cold day here.
Oh,
it's only
that's
like
fantastic.
Right,
okay, good. So you guys hopefully don't have to run your air conditioning and pay big bills. All right, now how to manage myeloma symptoms and side effects will be with a dear friend of mine, Teresa Michelle. She has a lot of acronyms after her name. Just take a look at that. And one of them that I'm really favored to is she's part of the International Myeloma Foundation's Nurse Leadership Board. All this information can be found at our website at myeloma.org. So you can dig deeper in about these speakers and what they've talked about. And let's go on to the next slide. You'll go into Craig's first. He'll do 101 in frontline therapy. And you're going to see a lot of information here today. So don't get uptight if you miss a slide. Shortly thereafter, we're going to have this on our website. You'll get a notice about it. And that's kind of the boutique experience we want to offer. You are part of the foundation. We are part of you. If you were to draw a little circle and put a P in the center of it for patient and draw a big circle around that, you'd see the IMF comforting you through education, support, advocacy, and research. That's what we've been doing for 30 years, period. So without further ado, I'd like to introduce a good friend of mine, Dr. Craig Cole. He's going to go into Myeloma 101 and frontline therapy, and we'll have some other discussion points later on. Thank you. Go ahead, Craig.
Thanks, Kelly, and thanks to the IMF. I've been Gosh, I've known you guys for a decade, I think.
Yeah,
has
oh,
been
easily.
And so, and just thank you for the great work that you do for our patients. Fantastic. So we're going to talk about a bit of perspective about myeloma, how common it is, the spectrum of plasma cell disorders. We'll talk about the diagnosis and the labs that you should know when you have myeloma. We'll talk about staging and risk stratification, and then we'll talk about treatments and upfront therapy. A bit about bone support and some new things about induction therapy for myeloma, and then some perspectives. So, fast facts about myeloma. Well, it's the second most common blood cancer or hematologic malignancy behind non-Hodgkin's lymphoma, which is the most common of blood cancer in the United States. And we have about 32,000 new cases last year of myeloma. And 131,000 people living with this disease last year. And we'll get back to that fact at the end of my talk. It is a disease of adults. As I have approached 50, I now don't use the term older adults. I use the term adults between 65 and 74. And it has a higher incidence in people of African descent than Caucasians, of about double that. And that's where there's a lot of research going into understanding why is it different and why is the incidence higher for African Americans than Caucasians. So what are those common signs and symptoms of myeloma? Well, about 60% of patients will have low blood count, so they'll have anemia, where their red blood count will be low. And that can lead to weakness and really fatigue. That patients will have fatigue and possibly infections. Also, the protein produced by the myeloma, the plasma cells, can get stuck in the kidneys, causing kidney damage and low kidney function, which can cause weakness and edema and puffiness in the legs. Myeloma will frequently, it always starts out in the bone marrow and then can move to the bones in order to attain the cytokines and the milieu that it needs to grow. That causes bone damage and weakening of the bones that we'll talk about in a bit in a lot of patients, and that can lead to bone fractures and bone pain when patients present. And because, again, myeloma will go to the bones in order to get the support of cytokines and milieu that it needs to grow, that it can have increased bone turnover, where, as you know, the bones contain calcium. And when the myeloma goes to the bones and in order to get to cytokines it needs to grow, it can release calcium, causing high calcium levels in the blood, which can cause confusion, loss of appetite, weight loss, and again, weakness and fatigue. And we use the CRAB criteria, or the CRAB acronym, to remind us of the presenting symptomatic signs and symptoms of multiple myeloma, with C being for high calcium levels, renal, meaning kidney, low kidney function, anemia with the lower blood counts, and the B standing for bone disease, or those lytic bone lesions that are seen on x-rays. But about 10 to 20% of myeloma patients will not have any symptoms, and we'll talk about that right now. So MGUS, the monoclonal gammopathy of uncertain significance, defined by Dr. Robert Kyle at the Mayo Clinic decades ago, where patients have a low plasma cell burden. They have very few plasma cells in their bone marrow, producing a low amount of monoclonal protein, and those patients are asymptomatic. It's a very common condition, about 5%, 3 to 5% of people over age 50, with a low risk of progression to multiple myeloma or related conditions. Smoldering myeloma is when there are more plasma cells inside the bone marrow, approximately 10 to 60%. And because of that, because the myeloma cells produce the protein, the M protein is higher. But again, in smoldering myeloma, patients are asymptomatic. They're usually discovered incidentally during when they have blood testing for other causes. And again, those patients don't have any symptoms. They don't have those CRAB criteria that we talked about, and a 10% per year risk of progression to active myeloma. Then there's high-risk smoldering myeloma, where patients have a higher number of plasma cells in the bone marrow, 20%, an M protein over 2, and light chains greater than 20. We'll talk about that test in a second. Or when patients have smoldering myeloma and their proteins continue to increase at a rapid rate. And we would call those patients high-risk smoldering myeloma. And they approach a 50% risk in 2 years to go to active myeloma. And then finally, there is multiple myeloma, where a biopsy or bone marrow biopsy has taken place showing malignant plasma cells. And those patients, again, have those symptoms, the acronym of CRAB, and those laboratory values that tell us that someone has symptomatic myeloma. In 2015, the IMWG, the International Myeloma Working Group, devised the SLIM criteria, where patients are asymptomatic, but they have a high plasma cell burden, lots of light chains being produced by the myeloma cells, or more than one lesion seen on a very sensitive scan, like an MRI or PET scan. And those patients have a very high risk, approaching 80% in 2 years, of developing symptomatic myeloma. And for that group, we now treat and consider them active myeloma. For MGUS, we observe or clinical trials, and we watch to see if it begins to evolve into smoldering myeloma. Smoldering myeloma, we usually watch, and we strongly recommend clinical trials. And high-risk smoldering myeloma is a very interesting subject in and of itself. There's a lot of research going in if we should treat high-risk smoldering myeloma. And we really very much recommend close observation and clinical trials, especially clinical trials, for us to understand that disease better. And for multiple myeloma, either diagnosed through CRAB or SLIM CRAB, or the SLIM criteria, those are the patients that receive upfront treatment. So when you have myeloma, as you know, myeloma is a diagnosis that is followed by lab work. The CBC telling us the blood counts, the comprehensive panel that tells us about the calcium, the kidney function, and the bone status. The beta-2 microglobulin and the LDH are two tests that we use for staging. The beta-2 microglobulin is an independent way to measure the number of B cells or plasma cells in the body outside of the M protein. And that is exclusively used for staging at the time of diagnosis. And the LDH, or the lactate dehydrogenase, is another test used for staging. And that is a chemical that's released by cells that are rapidly dividing. So if the myeloma is rapidly dividing and very active, the LDH will be higher. And then there are the tests we use to follow the disease itself. The SPEP is really and the free light chain measurement are the primary way that we measure how much myeloma cells are there. Instead of doing bone marrow biopsies once a month, we can just do the SPEP and the free light chains to see how much protein is being made by the myeloma cells, therefore telling us how many myeloma cells. The immunofixation tells us the type, if it's IgG, IgA, kappa, or lambda. And then there are the urine tests that we do, especially these days in a clinical trial setting, which is an independent measure, a way to measure light chains being produced by the myeloma cells. So the SPEP tells us how much myeloma there is. So normally there are 3 on the serum protein electrophoresis, which is what SPEP stands for. When you put the plasma inside a gel, it will break out into different sections, including the gamma region, which is where the where the M protein is. And in a monoclonal gammopathy, or when the plasma cells are producing that protein, the gamma part of the SPEP will go up, and that will tell us, and you measure the area under that curve, and that tells us how many plasma cells there are. So that's the monoclonal protein that we measure with the SPEP blood test every time that patients come in during therapy or during their checkups. And it equals the number of plasma cells. So again, instead of doing a bone marrow biopsy every month, we can do that test because you know those are equivalent. When a patient is undergoing treatment for myeloma and we reduce the number of plasma cells down, the M protein also goes down to tell us to make sure that the treatment is working. And so that's why it's critical for a patient to understand how we measure the myeloma. Some myeloma cells won't produce an M protein at all. They'll only produce the free light chains. And the way that we measure free light chains is either doing the urine protein electrophoresis collected over 24 hours or the serum free light chain test. In the serum free light chain test, it measures the amount of kappa and lambda light chains in the body. So normally we produce very small amounts of kappa or lambda light chain by our immune system. However, in the ratio between those two produced by the normal immune system, the kappa and lambda should be about 1. But if a patient has myeloma, the kappa or the lambda will be significantly increased along the same lines as what happens with the SPEP. Also, those myeloma cells will decrease the normal immune system and push down the lambda protein. And then the ratio between the two, instead of being 1 to 1, will be something like 100 to 1. That's because the kappa or the lambda are dominant and dominating the other light chain. And again, when we do treatment and we reduce the number of myeloma cells down, the kappa can return to normal. The lambda will then return to normal because the myeloma is gone or reduced, and the ratio will return to 1. And that's, again, when we celebrate. So it's important to know if your myeloma produces an intact protein, either IgG kappa or IgG lambda, IgA kappa or lambda, and rarely patients will produce IgD or IgE or IgM, the other immunoglobulins in their myeloma. But most patients, about 80% of patients, will have an intact immunoprotein or on the SPEP or M protein, and that's how we follow the disease. About 18% of patients will only produce light chains, and the SPEP won't work so well, but the free light chain or the 24-hour urine will measure that. And so we use those tests to measure how much myeloma there is in response to treatment. And then there are those patients that have non-secretory myeloma, where the myeloma is mutated enough where it doesn't produce any protein at all. And for those patients, we usually use the radiographic indicators of disease response, such as a PET scan. And then there is there's some new testing that can measure non-secretory myeloma, and specifically I forgot the name of the test, but we'll talk about it in a bit. Talk about that. The other ways that we measure myeloma, as we talked about, is with x-rays. We've been doing conventional x-rays for myeloma for the past 121 years. The very first x-rays that were done for myeloma were done in 1900, and those will show lytic lesions. However, that test is fairly insensitive, especially for lytic lesions in the pelvis and spine. And the PET scan has really become the main test that we use to diagnose and follow bone disease and multiple myeloma, because it's 85% more sensitive than the skeletal survey for lytic lesions and small lesions. And with the PET scan, the areas involved by myeloma will light up bright on the PET scan and will tell us where the myeloma bone disease is. And then to confirm the diagnosis and to obtain mutational information, we have patients undergo a bone marrow biopsy, again looking for greater than 10% involvement by plasma cells. Occasionally patients will have biopsies of spine lesions, of bone lesions, or plasmacytomas in order to make the diagnosis. When we do that bone marrow biopsy, we look at the mutational burden, or what mutations occurred to cause the myeloma to happen in the first place. So we get those mutated plasma cells from the biopsy, And we look to see, well, what happened? What chromosome abnormality or gene mutations occurred? And the main test that tells us about that is the FISH test. It can identify the number of chromosomes. It can show in the cancer cells and determine if there are excessive number of chromosomes, if the chromosomes are stuck together, which cause the myeloma. And it gives us really important prognostic information. There have been advances in more specific testing for mutational burdens in myeloma with gene expression profiling and plasma cell next generation sequencing, which also can give us more and more information about the mutational burden, and hopefully in the future will give us targets for molecular-based therapy to treat myeloma. So with the information that we get from the bone marrow biopsy and from that FISH testing, we can then categorize patients in two different sections. Standard risk patients, where they either have normal chromosomes inside the plasma cell via the FISH testing, or they have the 11th and 14th chromosome stuck together. And not infrequently, patients will have inside their myeloma cells more than just the single pair of chromosomes. We always have two sets of chromosomes in all of our cells, one from mom and one from dad. And then in myeloma, sometimes the cells will collect extra chromosomes that we call trisomies that are part of the mutations that cause the disease in the first place. High-risk myeloma are mutations where there are deletions of the 17th chromosome, gain of the first chromosome, or translocation of 414, the 14th and 16th, or translocation of the 14th and 20th chromosomes. And those have higher risks. They're a bit more difficult to treat and to maintain in those responses when first diagnosed. And recently we have two additional high-risk categories, the double hit and triple hit myelomas, where people will have more than one high-risk mutation in their plasma cells. 2 for double hit and 3 for triple hit myeloma, which is really becoming a very, very hot area of investigation of how can we help those patients that have very high-risk multiple myeloma. So with the cytogenetic and FISH testing, plus the beta-2-microglobulin and the LDH test, we can then stratify patients into stages, with stage 1 having a low beta-2-microglobulin, low plasma cell burden, a normal LDH and no high-risk features, versus the patients that have stage 3, where they have high beta-2-microglobulins, a higher plasma cell burden, higher kinetics of the myeloma cells, the high LDH, or high-risk cytogenetics, as I've mentioned, and/or high-risk cytogenetics, as I've mentioned before. And then there's stage 2, where a patient doesn't fit into either category. And again, this helps to stratify patients. And I'll show you in a bit how a lot of the new studies that are taking place in myeloma, staging is becoming important in myeloma land these days, because we're beginning to use different treatment strategies for different risks and different stages of multiple myeloma. So how do we treat myeloma in 2021? We use science. We use science these days. We use the immunomodulatory drugs of the IMiDs, thalidomide that Kelly had mentioned earlier, thalidomide and Pomalyst. We have the proteasome inhibitors, Velcade, Nilaro, and Kyprolis. And then recently, and thank goodness, we have the antibody therapies against myeloma, the immunotherapy, the Darzalex, the isatuximab, and elotuzumab. And it has been an incredible year for myeloma in that we've had multiple FDA approvals for novel therapies, completely novel therapies for myeloma that I've mentioned and will mention in a bit later today. So how do the IMiDs work? The IMiDs really are the backbone therapy of upfront therapy for myeloma. So how do these drugs work? Well, as I mentioned, they use science. And how does that work? Well, the IMiDs, Revlimid or Pomalyst, they inhibit DNA synthesis in myeloma cells to a very small degree. It's a very, very small way that it works. these drugs that were initially developed because they thought they would inhibit blood vessel growth in myeloma. But what it really does is inhibits two important cytokines for myeloma growth and proliferation, VEGF and basic FGF, where myeloma cells need those cytokines in order to grow and proliferate. Without those cytokines, not only are there less blood vessels, but the myeloma cells can't survive. Most, as I've mentioned earlier, myeloma cells live in the bone marrow. They need those bone marrow stromal cells in order to grow and proliferate. They will travel to other parts of the body to find cells that are like bone marrow stromal cells. And the IMiDs break that connection. Without being attached to a bone marrow stromal cells, myeloma cells can't survive. And then they also starve the myeloma cells of the cytokines they need to grow and proliferate and stay alive. And without those cytokines, the myeloma cells starve to death. And then one of the most important ways that the IMiDs work is that they get your own immune system, your own T cells, to fight and destroy the myeloma cells when they weren't doing that earlier. It's an incredible multi-pronged way how these drugs, this pill, can affect the myeloma cells and kill them on multiple different fronts. So thalidomide was the first in class, followed by Revlimid, that was approved in 2006, and then pomalidomide in 2013. And there are exciting new cereblon mediating drugs, such as the cell mods that are coming down the pipeline, are incredibly active in multiple myeloma. So the proteasome inhibitors, so how do those drugs work? Well, inside the myeloma cell, there are these little organelles, these little organs called proteasomes. And when myeloma cells produce their proteins, such as their cell receptors, to grow and proliferate, and those cytokines act on them, eventually those receptors then get old, and then they have to go to the proteasome to be destroyed. And so the proteasome helps the myeloma cell stay alive, especially because it uses cell receptors and adhesion proteins to help grow and proliferate. So what happens if you can block that proteasome? What if you can keep that from happening? What happens is it's like putting a cork in the exhaust pipe of the myeloma cell, that these proteins build up inside the myeloma cells. And what do myeloma cells do at their heart? They produce protein. They produce that M protein. And so if you stop up the proteasome and those proteins build up inside the myeloma cells, it kills them. And also the proteins that help the myeloma cells adhere to the bone marrow stromal cells don't work anymore, and it kills them. They starve to death. And so the first in class for the proteasome inhibitors were bortezomib, that was originally given IV and then given sub-Q, with excellent responses when they were first, and excellent responses now. Carfilzomib is an irreversible proteasome inhibitor that is IV. Again, excellent response rate, another backbone drug. And then just in 2015, Nanlaro, the oral version of bortezomib, was approved and is also very active in multiple myeloma. And then the immune therapies. So how do the immune therapies work? Well, on myeloma cells, there are different adhesion, there are different proteins that identify the myeloma cell as a myeloma cell. So each cell in your body has a ID tag on it that tells what the cell is. Myeloma cells have a very specific ID tag with SLAM7, CD40, CD138, and CD38 on it that tells the body that this is a myeloma cell. So what we can do, what they've done in the laboratory, is develop antibodies against those proteins, where anything that an antibody attaches to is tagged for destruction. Usually antibodies attach to things like bacteria and viruses to kill it. But people with myeloma don't produce antibodies against myeloma. So those antibodies are produced in the laboratory and against these different targets. So the immune system can recognize and destroy the myeloma because an antibody will be attached to it. Elotuzumab is the antibody directed towards SLAM7. The antibodies for CD40 and CD138 are investigational. And then CD38 has really become the hallmark antibody, the hallmark receptor for the antibodies against a myeloma in the way of daratumumab, Darzalex Faspro, the subcutaneous version of daratumumab, and isatuximab, and other antibodies that are currently in clinical trials. Recently, BCMA has become the new target for a myeloma. Again, BCMA is found almost exclusively on myeloma cells, and the new immune therapies, the immunoconjugated antibody blinatumomab, or Blenrep, and then recently approved CAR-T, the Isidel, and the bispecific antibodies are all directed towards BCMA. And the reason that BCMA is such an attractive target for myeloma is because, as this graph shows, it is exclusively expressed on myeloma cells and very little expression in other cells in the body. So how do these antibodies work? Well, the antibodies will attach again to CD38, SLAM7, or BCMA on myeloma cells. And so there's the surface targets. And these antibodies will stick to those surface targets, and it will activate the immune system, bring in the normal immune system, which will fire organelles at the myeloma cell and kill them. The other ways it gets those T cells activated, and they will go into hand-to-hand combat against the myeloma cells and destroy them. So there's a serologic immunity, there's a cellular immunity going after the myeloma cell, and also complement. Complement are proteins that attach to antibodies that bore holes inside the surface of the cells and causes them to literally, the cell to bleed to death. And so not only are the cells going after, but when the antibodies attach to myeloma cells, it activates complement that complements the immune system to destroy the cells. Also, when antibodies attach to these receptors on myeloma cells, it actually causes an internal short circuit inside myeloma cells, which also kills them. So the antibodies independently kill the myeloma cells, in addition to the activity of the immune system. And again, as we have mentioned with the other therapies for myeloma, that when those antibodies attach to the myeloma cell, the bone marrow stromal cells kick them out of the way. And again, without being attached to the bone marrow stromal cells, myeloma cells can't live and they starve to death. So this multi-pronged attack of the monoclonal antibodies is the reason why they are so active in myeloma today. So the tools of the trade for upfront therapy for myeloma are the IMiDs that we talked about, Revlimid and Thalamid, with Revlimid being the main IMiD that we use in upfront therapy. Proteasome inhibitors that we talked about earlier, Velcade, Carprolicin, and Laro. Occasionally we use chemotherapy. There's some regimens that use Cytoxan as upfront therapy, and we use melphalan, Alkeran, as sometimes for upfront therapy, but very frequently for auto transplantation. Steroids continue to be the mainstay of myeloma therapy. The steroids actually prime the cells for death when combined with the myeloma cells for death when combined with the other treatments that I've mentioned. We've talked about how the Darzalex, and I'll show you how that is being incorporated in upfront therapy for myeloma. So the treatment sequence for myeloma is we use upfront therapy that starts with induction and then consolidation with stem cell transplant. And then we follow that with maintenance therapy. There are lots of different regimens for induction therapy, but our main go-to has been Revlimid, or VRD, or Velcade Revlimid and dexamethasone. And I'll show you some of the other therapies that are being used, the 4 drug therapies for upfront therapy for myeloma. Consolidation is usually with stem cell transplant, though some patients will continue induction and defer stem cell transplant. The maintenance is with Revlimid, but occasionally Velcade, and for patients that are high risk, sometimes 2 or 3 drug maintenance therapy. When patients relapse, there are an incredible number of options that are available for patients when they relapse, including just since May of 2020, there has been a plethora of new approvals in myeloma, up into Isidel, CAR-T being approved as recently as March of 2021. And each point along the treatment sequence, we always recommend involvement in clinical trials. We would not have 5 drugs approved in the past year if it weren't for clinical trials. And that's how we beat the disease, is involvement in clinical trials. So with newly diagnosed myeloma, some patients are not transplant candidates, occasionally because of comorbid diseases or other medical problems that they may have that may preclude them from undergoing stem cell transplant. Again, this is why staging and understanding cytogenetics is important, because we can then stratify those newly diagnosed patients into high risk or standard risk. With high-risk patients, because it's harder to keep them into response with their first therapy, that we'll use frequently 3-drug induction therapy, either RVD or the addition of DARA to Revlimid and Dex, and either maintain those patients on RVD or DARA RD. For standard risk patients, is very similar of using VRD or using DARA VD. Some will also include other regimens that are used in Europe by using DARA with melphalan or DARA with thalidomide for 12 cycles, followed by maintenance therapy. For transplant candidates, we recommend for those high-risk patients, and this is really where it becomes critical in understanding the risk stratification, DARA RVD for high-risk patients, and occasionally using Kyprolis or carfilzomib RD for high-risk patients, followed by stem cell transplant, and then either 1 or 2 drug maintenance therapy with a proteasome inhibitor. And again, understanding if someone is high risk really becomes important in what their maintenance therapy is going to be. For standard risk patients, we use VRD or RVD for 4 cycles, followed by stem cell collection, and then and patients either then elect to undergo stem cell transplant at that time, followed by Rev maintenance, versus delayed transplant, where they collect their stem cells and delay their transplant until their first relapse. And again, that is followed by Rev maintenance. Our preferred regimen, and at Michigan State, about 80% of our patients undergo stem cell transplant after 4 to 5 cycles of RVD, and again, followed by Rev maintenance, or if they're high risk, Velcade or 2-drug maintenance therapy. The goal that we have when we treat myeloma is cytoreduction, getting the myeloma burden as low as possible. And when we first see patients with myeloma, their myeloma burden is over 1 trillion cells. They have symptoms, they feel sick, they have bone pain at diagnosis. And then we treat, and when we do our treatment, we're lowering the amount of plasma cells down. That when there's a 50% reduction in that M protein, that's why it's important to know if you have an M protein or the free light chain measurement, it reduces that M protein down. When it goes down by 50%, that's a partial response. It goes down 90%, that is a very good partial response. And all the way down to a complete remission, where there's no M protein recognized, or the free light chain ratio has been normalized. Below that, there are more sensitive measurements that are under investigation and being used. The minimum residual disease, or MRD, can be measured either by flow cytometry or next generation sequencing. And I had mentioned earlier there's a sensitive test for patients that have asecretory myeloma called mass spectrometry, and that can also be used to complement the MRD measurement in myeloma, because it finds very low amounts of protein in the blood, lower than that of what we can get with just an SPEP and the free light chain measurement. And so again, the goal is to reduce the disease down to the lowest amount and leave it there. So how do you do that? Well, we use the combination of induction therapy and transplant. And I tell my patients that what this is like is boxing. I don't know anything about boxing. I barely watch a boxing, thing. I've seen more cartoons of boxing than I've seen actually real boxing. But I know that when a boxer will use its right hand, the right hook, which is RVD, and keep hitting the disease, knock it down, have it almost knocked out, and then you deliver the left hook. The myeloma cell is not anticipating the chemotherapy that's associated with the stem cell transplant. It has been almost knocked out with RVD. You deliver that left hook with transplant, and the myeloma is knocked out. And then you use maintenance therapy to make sure that it takes a long time for that boxer, the myeloma boxer, to get back up. So the right hook of RVD plus the left hook of stem cell transplant knocks the myeloma out. How do we know that? The IFM study from France told us so. That this was a study that got patients that were 65 years or younger. The reason that an age limit was set on it was not because of the stem cell transplant, because in Europe that is the standard of care there. To transplant 65 years and younger. And those patients are randomized to either receive 8 cycles of RVD with no transplant at that time, versus RVD for 3 cycles, auto transplant, consolidation, and then Rev maintenance. The caveats to this is that the Rev maintenance is only given for 1 year, and in the United States, we have patients receive Revlimid until relapse, so indefinite Rev maintenance. Also, at the time this study was done, there were not a lot of options for relapse when the patients would relapse. And so the patients that did not undergo stem cell transplant initially ended up getting, about 75% ended up getting a transplant anyway. So really what this study told us is really, should we do transplant up front? And because some patients needed as a salvage therapy when they relapsed after this, they end up getting transplant later. So it's a transplant up front or delayed transplant. The follow-up was updated last year at 93 months. And this again the study was conducted before the routine use of carfilzomib or daratumumab in Europe. So how does this delayed transplant versus upfront transplant look? Well, when you compare the two, upfront transplant did have more side effects. They did have more anemia, GI side effects, and infection. But a lot of those happened in the hospital. A lot of those happened while patients were hospitalized. So that was controlled, under controlled circumstances. For time to relapse, the progression-free survival, transplant won. Patients stayed in their remission longer when they underwent transplant than not. Transplant wins for time to relapse. For overall survival, actually it was equal between delayed transplant and upfront transplant, because most patients, again, when they relapse, when they didn't receive transplant up front, they received transplant later. So that told us that it doesn't matter if you get the transplant later or up front, the way of overall survival. But since the disease is going to be at its lowest burden up front, we prefer giving the transplant up front. But for overall survival, even Steven, Deeper responses, you get deeper responses by the right hook and then followed by the left hook. The disease is better controlled. And when it comes to those very deep responses, MRD negativity, again, transplant wins significantly lower. And it was MRD measurement, those very, very, very low, where you cannot find one myeloma cell in a million normal cells, was a strong predictor of how long patients stayed into response and overall survival. So the median time to response and MRD negativity transplant wins. I should mention that the median time to response on this study was a bit lower than what we see in the United States because the patients were only on Revlimid maintenance for 1 year. In the United States, the progression-free survival for standard risk patients are more like 6 years for patients that undergo transplant. And so and it's in part because of what we found out with Rev maintenance. So again, with stem cell transplant, which isn't for everybody, but to know that it does cause deeper responses and longer time to progression. So what I'm always asked is, well, that was, 2009. What about today? Well, just at the most recent ASCO meeting, there was a study that was done called the Forte trial, and it did something very similar to the IFM. It randomized patients this time between 3 arms, and again, this was a study that was done in Europe, and it randomized patients between Kyprolis, Cytoxan, and Dex versus Kyprolis, Revlimid, Dex, and patients either went on to transplant followed by consolidation, or they went on to receive just Kyprolis and Dex for 12 cycles and no transplant. The Kyprolis Cytoxan arm was inferior to the Kyprolis Revlimid Dex arms, and so we haven't really talked a lot about that when we've gone to meetings. And really, this ends up being a study of transplant versus no transplant using KRD as the induction regimen. And what we found, and again, this was just recently at the last ASCO meeting last month, that KRD transplant prolonged the progression-free survival in patients, or the time to relapse, versus doing just chemotherapy or just doing induction therapy alone. For standard risk, high risk, and double hit, and it is and the reason that this is highlighted is that this is a study that identified those high risk and double hit patients to tell us, again, that transplant is important for those patients. And when you look at MRD negativity that was sustained, again, transplant wins. So transplant still wins. That right hook followed by the left hook still wins in 2021. So what do you do after transplant? Well, we do, there was a study looking about what should we do after patients undergo transplant, because I showed you these studies frequently have consolidation regimens after, so RVD followed by transplant followed by more therapy. And so there was a very significant study done in the United States called the Stamina study, which after transplant randomized patients between Revlimid maintenance versus undergoing consolidation versus a tandem transplant. And everyone post-transplant then either started Revlimid maintenance or after consolidation or their second transplant underwent Rev maintenance. So everyone ended up on indefinite Rev maintenance. And what this trial showed is that there was no difference in time to relapse or overall survival between patients if they underwent consolidation after RVD therapy, tandem transplant, or just going straight to Rev maintenance. And because going straight to Rev maintenance is the easiest, that really has been has been our standard of care, is after transplant, instead of undergoing consolidation, patients go to Rev maintenance. Recently, there is suggestion that maybe high-risk patients may benefit from 2 transplants, and we still need to get, I feel, some more information on that, especially with some of the new induction regimens that we have for our high-risk patients at this time. So I've mentioned a lot about Rev maintenance, and the reason that I've mentioned so much about Rev maintenance is that there have been 4 randomized trials showing the benefit of Rev maintenance versus no maintenance, and with improvement in progression-free and overall survival. And we still don't know how long people should continue it, but all these studies have shown that that favors for overall survival Rev maintenance after stem cell transplant or continued maintenance without stem cell transplant. There are ongoing trials with using the proteasome inhibitors, and again, there have been trials that shows that for high-risk patients, proteasome inhibitors are the maintenance drug of choice. Part of the stamina trial that I mentioned earlier did allow patients to decide if they wanted to stop their consolidation therapy after 3 years. And so patients were allowed to either stop or continue Rev maintenance. And what happened is that the patients that stopped the Rev maintenance, and this curve shows that red curve trails down because it shows the increased probability of those patients relapsing. So patients who stayed on Rev maintenance, there were some patients that were beginning to relapse after induction therapy that were maintained on Rev maintenance. But those that stopped, there's a greater probability that they would relapse. So right now, we don't know how long patients will stay on Rev maintenance, but we recommend, based on this, that past 3 years is preferable. And so what about bone support? Well, Paige, we've mentioned earlier that patients with myeloma have weakened bones doing osteolytic lesions. And it's really critical to use those bone strengthening drugs such as pamigenate Zometa to strengthen the bones. We know, or the monoclonal antibody Xgeva, because we know patients can have bone pain and weakened bones. And these drugs help them to strengthen the bones so that patients can conduct their activities of daily living and feel well. Vitamin D and calcium supplements also help in bone healing and are really important, so make sure you ask your doctor about calcium and vitamin D support. And we also obtained the help with our pain control colleagues, our orthopedic, physical therapy, and physical medicine colleagues, as well as our radiation colleagues when patients have pain. So what about some of the new stuff in induction therapy? Probably the biggest news in induction therapy, and what is really beginning to change the standard of care, is the Griffin study, which was a study that randomized patients between either doing RVD plus DARA versus RVD alone, which is the current standard of care. So this is a classic study that compares the current standard of care versus DARA RVD. Everyone underwent stem cell transplant, followed by consolidation with DARA and then maintenance therapy with DARA Rev versus Rev alone. And the primary endpoint of this disease, of this trial, was a stringent complete response. And so with secondary endpoints being complete response overall response rate and VGPR. And what this trial showed was that the number of patients that underwent that stringent CR, so no evidence of myeloma in the bone marrow by conventional measurement, and no M protein present, more patients that had the DARA RVD had those responses than RVD. And when you look at depth of response, again, you got the deeper responses with DARA RVD than RVD alone. RVD responses, 91%, is still excellent, still an excellent response, but there were deeper responses with the addition of daratumumab. And when you look further out, when patients were on the maintenance phase of DARA Rev versus Rev alone, these responses deepened over time. And that's what in patients that we've treated with, high-risk patients we've treated with DARA RVD, we've seen that exact thing, that as long we keep them on therapy, the deeper their responses. And so excellent. Again, with Rev RVD alone, excellent responses, a bit more excellent responses with the addition of daratumumab, and we really need to see what the long-term results of this trial are going to be. But it is really rapidly approaching the standard of care, especially for our high-risk patients that need those very, very deep responses. Here is a collection of a lot of the studies that for 4-drug induction regimens. Again, and if you look, I kind of highlighted these studies showing that these antibodies versus the standard induction regimens, that response rates are 90, 95, 100%, 100%, and deep responses across the board. And that's why really I think where we're going are the 4-drug induction regimens. So where you look where we are, when Kelly and I first started doing this, back when I had hair, we were using melphalan and prednisone and vincristine with pretty crummy response rates back then, 35% response rates. Back in the ancient days. Then thalidomide, bortezomib, we were doing 2-drug induction therapies where we improved those responses and we got some better deep responses. But you look in the modern era, using 3-drug and now 4-drug therapy, look at where we've gone in the past 20 years, from 35% response rates now to the standard really is 98, 99, 100% response rates. And we're getting those deeper responses. So it is important to know, what are your goals of therapy? I sit down with every one of my patients with newly diagnosed myeloma, and we talk about what do we want to do. And our goal is usually to reduce the myeloma down to the lowest amount to prolong progression-free survival and overall survival. And it's important to know, to read your protein, to see that protein, the myeloma cells being reduced, and seeing that protein going down so you know when to celebrate. Knowing your stage and risk, because that is becoming more and more important as we have these new therapies and clinical trials coming out. Knowing your treatment options, and knowing the side effects and who to discuss the side effects with. Because you shouldn't, if you have side effects, don't suffer with that. Tell your doctor, tell your extender what's going on. Assemble your care team. This is not a fight that you have alone. You have to assemble a care team and always obtain a second opinion, because things in myeloma are changing very quickly. And you need to be aware of those changes, discuss those changes, and ask about clinical trials. So as I've mentioned, the 3-drug therapies response rates are greater than 98%. We're moving to 4-drug therapy. We're getting super deep responses, and we're approaching 100% response rates. We had 7 drugs approved and indications approved by the FDA in just the past year. And no other cancer is doing this. No other cancer has that many approvals in 4 new classes of drugs, all incredibly active for myeloma. And with these novel therapies, we are now pushing survival, or the survival rate, out over 10 years. And it has just been incredible. The proof of that is that the number of people living with myeloma in 2004 was just 54,000. And over the years, as we have had all these breakthroughs in myeloma, the number of patients living with this disease has more than doubled. It has been an incredible, incredible journey in the past few years to see the impact, how people are living with this disease. We haven't cured myeloma yet, but it is survivable now. Thank you. And I will take a look at the question box.
Hey, Craig, could you, sorry for the delay, I hit the wrong button on the computer. Could you answer question 1 and repeat it out to the audience? That is about, let me look at it. Please explain SLIM criteria.
Yeah. So I will do that. So in 2015, prior to 2015, the way when we were trying to go to the insurance companies to ask to start treatment for myeloma, the only way that we can convince the insurance companies that we need to treat patients with myeloma is if they had active symptoms of disease. They had those high calciums, and they had the low kidney function. They had anemia. But we knew that there were patients that were going to have that. It was obvious that patients were just about to have symptoms, and it didn't make any sense for us to wait until somebody got sick to begin treatment. And the Mayo Clinic actually worked at seeing, well, how can we predict patients that are definitely going to get sick with myeloma so we can treat them early? And the main features of patients that were imminently about to have symptoms, where we didn't have to wait for them to have the high calcium or renal or decreased renal function, was the slim crab. So if you have greater than 60% plasma cells on a bone marrow biopsy, they do that bone marrow and they say it's 80%. In the next 2 years from that bone marrow biopsy, there is a greater than 80% chance that something bad's going to happen. So we treat people then. If the light chain ratio is really high, and that ratio, the light chain number is really high, that tells us that something's going to happen with their disease in the next couple of years. A 90% chance something bad's going to happen in 2 years, so we treat those people. And if they have a lytic lesion on a very sensitive test that we obtain on patients when their skeletal surveys are negative and we think they have smoldering myeloma, we always get a PET scan to see, are there any hidden lytic lesions? And if they have more than one, there's about a 70% chance something bad is going to happen in a couple of years. So we beat the disease to the punch. And that's the slim crab. Sometimes with slim crab, because there's a 2-year window before something will happen, that we just plan, we observe carefully, but more likely than not, we really plan on beginning treatment to try and beat the disease to the punch.
Excellent response, and I even understand it more, so thank you, Craig. We're going to take a little break right now to stretch and do what we do. It's going to be 10 minutes, and you'll have some countdown here on your screen. And thank you again, Dr. Cole. That was fantastic.
Oh, thank you.
Welcome back to the International Myeloma Foundation's Regional Community Workshop webinar. My name is Kelly Cox, and I must apologize right away because I said one of our sponsors the wrong way. It's Oncopeptides. I have no idea what I said. Sorry about that. It does happen. I'm dyslexic, so I saw all the letters and I got confused. It's like Dr. Hari's first name. There's no way I could ever say it. Now we have another. Dr. Hari, when did we work? Was it in 2006? Is that when we did a workshop back there?
Yes, probably 2006.
Oh my gosh. Well, I've learned a lot more since then, but I know you know a lot more than I do. So why don't you just take it away and talk about relapse therapy and clinical trials? And Dr. Hari, thank you so much.
Thanks so much. Thanks, Kelly. Thanks, Amira. Thanks, everyone, for listening in. And I really enjoyed Dr. Cole's talk. My talk's going to be a little bit shorter. It's only 30 minutes. And I'm happy to take questions after that. So I'm going to talk about relapsed myeloma. So the unfortunate nature of myeloma is that most patients have experienced relapse at some time. And that's really why we call it incurable. And it's a very difficult term to adapt to when you're newly diagnosed. But the good news is that there are really a lot of choices. And I would argue that at relapse, you need a myeloma expert more than when you at initial therapy. Initial therapy, as you saw from Dr. Cole's talk, the choices are, 3 drugs or 4 drugs, and the drugs are kind of, the classes of the drugs are very similar. Do a transplant, don't do a transplant, those kind of questions. So the questions are more limited. As you relapse and as you have more and more relapses, later relapses, the choices become more complicated, and you need a true myeloma expert in your team. You don't need to get the therapy at the expert's clinic, but at least go and see them. Or, in these days, you can even do video visits. So the past 5 years, there are so many drugs that have come out. And these are the drugs that have came out since 1958 to now. 1958 is when we had melphalan, which is still being used nowadays more and more in the context of transplant only. But still there is melphalan, people taking melphalan by itself as a pill. And there is a new drug that came out about a couple of months ago called with melflufen, which is a melphalan derivative. So that drug is still in play because it works against myeloma. And the argument is that patients need exposure to as many of these drugs so as to maximize the time they live with myeloma. So if every drug works but no drug cures, the more drugs you can see in your lifetime with myeloma, the more time you will get of disease control. So that's kind of the argument. Now we have CAR T cells approved too. So let's define some terminology around what we are talking about. So almost everyone starts out with inactive myeloma, as you just heard, like either MGUS or smoldering myeloma. You may not know that you're an MGUS. In fact, if you don't do a test and look for MGUS, you will not know that you have MGUS. But eventually, some patients with MGUS will get down to myeloma. And when it gets to the stage of active myeloma, you need treatment. If at that point the treatment does not work, so you start VRD, treatment doesn't work, then we would say that the person is refractory, meaning none of the three drugs in VRD work. So that's called primary refractory disease. So refractory means treatment did not work. And it could be refractory to one drug, you could be refractory to two drugs, you could be refractory to all the drugs. And then relapse means you actually had a response at some point, and then your disease came back. So relapse and refractory are two different terms. And you can relapse but not be refractory. So say you got VRD treatment, you went into remission, and you're in remission for a little bit or a long time, and you're not off of all treatment, and then your disease came back, then you're relapsed, but you're not refractory to anything. So all the treatments that are available in myeloma, they will still work for you. So relapsed without being refractory to anything is actually better than being in a relapse with some refractoriness to one or more drugs. Unfortunately, at the end stage of myeloma, after multiple relapses, patients become refractory to everything that's available in the market. So that would be called multi-refractory disease, or in these days, we have 5 major classes of drugs. We have the IMiDs, like Revlimid and pomalidomide and thalidomide. We have the proteasome inhibitors like Velcade and Kyprolis. We have the monoclonal antibodies. And then for each of those IMiDs and proteasome inhibitors, we have 2 types of drugs, the Velcade derivatives and Kyprolis. And for IMiDs, we have Revlimid and pomalidomide. So we have basically 5 major drug groups. And if you're refractory to all 5, we call that penta-refractory disease. And that's not a good place to be in. That's where CAR T cells and other things have shown a lot of benefit. And now they're approved. It's for patients who have had at least 3 relapses or 4 lines of treatment. So the landscape of relapsed myeloma is, initially, as Dr. Cole said, you get induction treatment, then you may or may not get a stem cell transplant, you get a maintenance treatment. So there are a lot of questions about how you treat initial therapy, and that's what we discussed before. And you're on maintenance, and at some point, patients relapse. The average time to relapse after a standard initial induction followed by maintenance, in my mind, is about 5 years. That means half the patients have relapsed at that point. And the other half is going to continue. And some people may be even cured. We don't know that yet. But if you're on Revlimid maintenance and you relapse, the assumption is that you're now refractory to Revlimid and you get treatment without Revlimid. If you had a break from Revlimid for several months or even years, and then you relapse, that's a first relapse without being refractory to anything. So this is essentially how it looks like, RVD, transplant, maintenance, without a break or while on maintenance is an important question. And what you did do at relapse is informed by what you did prior to the relapse. So this is what we expect, a median of about 48 months in this French study of auto transplant followed by Revlimid maintenance for a year. And that 48 months is about 4 years. And if you look at the US studies, we are about 50 months, but we do maintain Revlimid for a longer period of time. And how can you predict if someone's going to relapse sooner versus later? So studies have shown that if you get to a state with very little myeloma in your body, in the bone marrow, that is called a minimal residual disease negative state, you tend to relapse much later. So this is about 90-month follow-up of the patients in that French study. This is a little update of that study from a few months ago. At 90 months, so that's almost 8 years or so, 7.5 years, you can see that the people who are MRD negative and had a transplant, those are the people who are doing well. 50% of them had not relapsed even at 84 or 96 months. So at 8 years, 50% were still in remission. That's a great number. And let's assume that another 10 years later, if some of these patients are still in remission, they're pretty much as good as cured. So we call it a functional cure. Because the functional cure just means that we don't know if you're cured, but we think you may be. And we just have to follow you. So it's not a real cure would be when you say, okay, you're cured, you don't need to come and see me again. I'm not going to do any more myeloma labs on you. I'm just going to do some blood checks once a year or so. We unfortunately cannot be in that situation with myeloma with any treatment. So my point is that avoiding a relapse is altogether is the best thing to do, obviously. And the second best thing to do, if we cannot avoid it, is to delay it as long as possible. And how do you know you're going to do really well? This is a prediction. So if you want to predict if someone's going to do really well, you have to do an MRD test. And we don't make any clinical decision-making, we don't have too much clinical decision-making evidence based on the MRD test, but we still do it to make a prediction. Sometimes the prediction can be wrong. So if you look at this MRD test again, even the MRD negative people who had a transplant and MRD negativity, 25% of them had relapsed at about 3 years. So even if with an MRD negative test, you can come off of this curve. This curve, being on the curve is good. So at relapse, what do you do? So the big fundamental question that people were trying to answer at that time were, should you just do Revlimid Dex or bortezomib Dex or Velcade Dex? These two are combination treatments that were available for relapse disease. Or should you add one more drug and make it a 3-drug combination? So a variety of studies were done. So you can see the Panorama study did panabinostat, Velcade Dex versus Velcade Dex. Castor study did daratumumab, Velcade Dex versus Velcade Dex. These are all the Revlimid-based studies. So the control arm, or the people who were standard of care, was Revlimid and dexamethasone. And in the study, they added one more drug, Kyprolis Revdex, Ixazomib or Ninlaro Revdex, daratumumab Revdex, elotuzumab Revdex. So 3 drugs versus 2 drugs. And I'm sure everyone here knows the answer. If you did 3 drugs, you did better than 2 drugs. But these are all in medicine. We just don't assume things are better because you add one more stuff. Sometimes adding more stuff can be harmful. So if you look at the longest progression-free survival, which means when somebody starts on this treatment, how long can you expect for them to be progression-free and live? So that's about 2 years plus for the ASPIRE study for the KRD arm, and for these other studies, it was a little shorter. But in the POLLAX study, the daratumumab Revdex study, it is still ongoing, and it's easily ahead of any other study. So it's one of the combinations that we use at relapse is the daratumumab with imid and dexamethasone, or carfilzomib with an imid and dexamethasone. And if you're Velcade sensitive, Velcade with Revlimid and dexamethasone should also work. So it's a combination. The message is that 3-drug combinations are better than 2 drugs, and you try to use the combination to which the patient is not refractory. Meaning, if you're coming straight off of Revlimid, you stop the Revlimid and you find 3 drugs that do not involve Revlimid. If you've been off of Revlimid for a while, you use Revlimid-based combination. So then there are another set of studies which are more modern studies of relapse. So this is all early relapse, people who relapsed first time or second time, like that. So these studies looked at daratumumab, carfilzomib Dex, or Dara-CARD, DKD, or versus carfilzomib Dex. And this Apollo study used daratumumab with pomalidomide and Dex versus pomalidomide and Dex. Isatuximab is another monoclonal antibody similar to daratumumab, and this is a study that looked at Isa-Pom-Dex versus Pom-Dex. So there's a lot of drug names coming at you. And if you're early in your disease phase, don't get scared by these names. These are all drugs that, hopefully you may not need to see, but if you need to see, they're very well tolerated drugs. Daratumumab and isatuximab are monoclonal antibodies, which means that they're targeted drugs that looks at the signature of the myeloma cell surface and only targets the myeloma cell. Pomalidomide is like Revlimid. And so here again, the message is the same. A monoclonal antibody combination with either a second-generation proteasome inhibitor such as carfilzomib or a second-generation IMiD such as pomalidomide, the 3-drug combination is better than just the 2 drugs. So all of these studies show the same thing. you do better in a 3-drug combination. So my recommendation is to go on one of these combination regimens, again, based on what you can tolerate, what you can have seen before, etc. And these are all, if you cannot have an IMiD, you could have DARZALEX with daratumumab with bortezomib, or daratumumab with carfilzomib, or isatuximab with carfilzomib. If you have if you're sensitive to pomalidomide, then you can have Darapom, Isapom, or bortezomib Pom, or Velcade Pom. So these are all data. So we expect about 60% of patients to have a response, a large number of patients to have a VGPR, or very good partial response, which Dr. Cole already explained, or better. And we expect that if you're not in that 60%, you will have to go on to another treatment. The main complications are fevers, infections. About 10% of patients get that. Low blood counts are pretty common, especially after relapse, because your bone marrow pool or reserve is not so great. We always ask patients and doctors to watch out for neutropenia. And this is daratumumab Pom-Dex. It's another great combination. Kept people out of trouble for about a year plus at that point. And this is the study of Dara-KD versus carfilzomib Dex, Dara-carfilzomib Dex versus carfilzomib Dex. Daratumumab these days is a shot in the belly, carfilzomib is an IV, and again, you can see that patients are enjoying a very, on the 3-drug combination, are enjoying a very plateau here, and as far as 24 months out, so it's 2 years later. So these are again, Velcade plus a IMiD combination, or carfilzomib plus an IMiD combination. These are all the combination studies. I just have this for being comprehensive. You can see that what I would like you to look at is people who had a prior Revlimid here. This is a number called row number 3. You can see that prior Len percentage and Len refractory. You can see that 42% had exposure to lenalidomide. In some of the studies, 70% of patients were Revlimid refractory. Even then, you can establish a remission or a response in a significant number of patients. 80%, 70 to 80% of patients respond to these with a partial remission or better. And all of these studies suggest that there are multiple options, even if you're refractory to one or more drugs. So these are all combinations of 3 drugs versus 2 drugs without using a IMiD such as Revlimid or pomalidomide. Now let's move on to some of the newer drugs that are there, which I think are more exciting than these combinations that I showed you. This is from the decade that just went by. This is about the decade that's coming. So Dr. Cole already talked about BCMA. That's another protein molecule that is on the surface of the myeloma cell and is very localized to that particular cell. So you want to destroy myeloma cells, you can have a targeted drug that goes and attaches to that molecule on the surface of the cell. And this targeted molecule is also attached to a tiny amount of chemotherapy. And this tiny dose of chemo gets delivered on the surface of the myeloma cell. So we call that a ADC, or antibody drug conjugate. So there's an antibody that detects the surface of the myeloma cell. And on top of that antibody, we have fixed a little bit of a drug. So the drug is delivered right on the top of the myeloma cell. So you can actually get a lot more cell kill with that. And the antibody also engages your immune system and causes other cells to go there and kill it. So this is the first BCMA targeted drug that got approved. It's called belantamab. And the problem with belantamab is that although it's a very effective drug and can be, it's very tolerable, it is a steroid-free treatment, but it does have one toxicity that's a little concerning, which is that it can cause deposition of that chemo drug in your eye, on the cornea of the eye, which can cause eye irritation, and sometimes what we call microvesicles in the cornea, which can lead to reading difficulty, driving difficulty. It is thankfully temporary and it recovers, and all you do is hold the drug. So this is a drug that's given IV every 3 weeks, and sometimes we hold the drug for 3 more weeks and then it goes away. It is a drug, therefore, that has to be monitored very closely by the oncologist in conjunction with an ophthalmologist. So you have an ophthalmologist on your team too if you're on this drug. But BCMA has been targeted by other mechanisms. These other mechanisms include CAR T cells, or what we call bispecific antibody. CAR T cells are specialized cells that are created out of your own immune cells. So they are kind of highly personalized to the patient. if you have you can collect your immune cells and make them into CAR T cells. Bispecific antibodies are, on the other hand, are like a double Velcro. So one end of the Velcro, or one side of the Velcro, attaches to the myeloma cell. The other side attaches to T lymphocytes, which are immune cells that can kill cancer. So what we are trying to do with the bispecific antibody is to put the double Velcro on top of the myeloma cells, and if an immune cell is passing by, that guy attaches to the other side of the Velcro, and then what happens, what we call an immune synapse, which is what is being shown here. One side of the Velcro is red, other side of the Velcro is green, and the green pulls in the immune cell, the red pulls in the myeloma cell, and then that leads to what we call a synapse. And at the synapse, energy flows through from the T cell and kills off the myeloma cell. So this is a very, very efficient way of killing myeloma too. And these two things are going to completely change the landscape of myeloma, in my opinion, coming in the next decade. So the first BCMA targeted CAR T was just approved about 3 months ago, and it's called ide-cel, or Abecma, A-B-E-K-M-A. So Abecma was approved recently, just a few months ago. So this is the study on which it was approved. It's called the KARMA study. In that study, 150 patients were screened for the study. 140 were collected T cells. Leukapheresis is a collection of T cells. Just like you have collection of stem cells, you can do a leukapheresis, which is actually easier to collect off of your body. No drugs before. You just go there and they will take off your T cells in about 4 hours. And those T cells get sent off to the company, who then makes those T cells into potent cancer-fighting cells that can specifically recognize BCMA on your body. So it's your own T cells. They come back about 4 weeks later with the ability to recognize and attack myeloma, your own myeloma. So so you get admitted to the hospital, or you can get a little bit of chemo as an outpatient, and then you get the CAR T cell infusion, kind of like how you got the stem cell infusion. So when the CAR T cells go in, right, there's really no side effect immediately, but they can produce certain unique side effects. So we need to talk about that in a second. But they are highly effective, and as I will show you here, these patients who entered the study had an average of 6 prior regimens. So they had relapsed at least 6 times before they got to the CAR T. They had an overall response rate. If you look at the middle, the third thing here, that's the effective dose of 450 million CAR T cells. You can see that the overall response rate is 82%. And the majority of those patients, vast majority, were either in a complete response or a VGPR. So it's a very, very effective treatment just with one and done approach. It's just one-time treatment. So it's super effective. And there are 2 toxicities of this treatment that we have to talk about, but the main point is that it's such an effective treatment. But still, it is not a cure, and that's important to recognize, mainly because this is patients who have had multiple prior relapses, and also because myeloma finds a way to come back even after all this. But what happens to most of the patients who get a CAR T is that their whole process her myeloma journey gets reset. We see that although the progression or the relapse after CAR T is about 8 months to a year, most people are alive 2 or 3 years later. So that means that that disease-free, treatment-free interval that you get after CAR T probably resets your disease, and you can actually regain your function, regain your strength, and be able to match the myeloma better when it eventually does come back. This is the other CAR T cell that's in development. It's called cilta-cel, and this study was what looked at that, CARTITUDE-1. This is not approved yet, but this hopefully will be very soon. And in this study, the response rates are even better, 97% response rate. That means out of 97 patients who got the treatment, 94 responded. And as you can see, almost everyone, 93% had a VGPR. So literally everyone responded except for 3 people. And the time to response is very quick, 1 month. And this appears to have even longer progression-free survival than the ide-cel that we already have approved. So this is the progression-free survival of CARTITUDE-1. And as you can see, if you got to a complete response with CARTITUDE-1, you actually stayed in response even longer. So these are all very exciting things for our patients and for us who treat the disease. There are many other CAR T cells in development. You can see there are the Karma-1 we talked about, Cartitude-1 we talked about, then there is Lumicar, there is Prime, there is CRB402, which is a variation of the Karma, and then there is a off-the-shelf CAR-T that's made with other people's T cells, and you just get it as an infusion off the shelf. So there is no collection process, there is no manufacturing delay. You can just get it from the, and all of them have an efficiency of response of at least 60 to 70%, and for some of these 90% plus. So it is an exciting world for a new form of immunotherapy. The other form of immunotherapy is what I just told you, the double Velcro approach, or making a T cell come near the myeloma cell. So those are called T cell engagers. So what we need is a target that identifies the myeloma cell and another target that pulls in the T cells. The side of the T cell, of the T cell side of that Velcro, is something called CD3, which is present on T cells normally. And the side on the myeloma is BCMA, but we now have other targets too. So BCMA targeted bispecifics are, some of these are represented in the slide here. So you can see there is teclistamab, there is TNB383B, there is Regeneron 5458, there is AMG 701, there is elranatamab, that's another compound. They're all very efficient, again 70% plus response rate, and they have a side effect known as CRS, very similar to CAR-T. We'll talk about that in a second. And there are many more new drugs happening. So the best part about CAR-T or other immunotherapy is that they are highly efficacious. They seem to be agnostic to the disease risks. So these are responses that are happening in patients who have had multiple 6 to 14 lines of treatment in the past. So at that point, most patients have high-risk disease. Almost everyone is considered high-risk because myeloma cells acquire mutations over and over again as they relapse. So by the time you have relapsed several times, the myeloma is very high risk. But these immunotherapies seem to be agnostic to the disease risk. And there are two side effects that we need to talk about. One is called CRS, and that stands for cytokine release syndrome. This is a syndrome where once you get the immunotherapy, your immune cells are going and attacking the myeloma cells. And while they are doing it, they multiply. So they multiply several fold, 10-fold, 100-fold, 10,000-fold sometimes. And that leads to it can be described as the worst ever flu you had. And this is essentially a reaction that can be associated with high fevers, low blood pressure, and it looks like the person is septic, but they don't have an organism or a bacteria that's causing the sepsis. And this needs to be sometimes managed in the ICU. You need to be near the CAR-T center for managing this, and you need to have a team that's expert in managing that. So that's why I said again at the beginning, if you have relapsed disease, you need more expertise in your care. And if you get CAR-T, you have to live near the CAR-T center for at least 4 weeks. And you can't be driving, you have to have a caregiver. It's a little bit like a transplant, but it's not as intense as a transplant in my experience. But if a person gets CRS, which actually many people do, you need a specific antidote for that CRS called tocilizumab, which is, again, a requirement by the FDA that you have to have tocilizumab at the CAR-T center before the patient even gets CAR-T. So we can actually switch off the reaction if we identify and a patient gets to us quickly. So we make the patients live, in our case, within 30 minutes of the hospital. And another syndrome that can happen in this same vein when a person has CAR-T is something called neurotoxicity or ICANS. It's a long word meaning, it's an acronym for the third person has some brain side effects. And the brain side effects, again, thankfully, are not permanent. They're reversible. And first it starts off with the person feeling like they can understand everything, but they cannot get their words out. So it's a little confusion at the beginning. But it can actually go, if untreated, it can go into a serious condition where the patient can actually become completely delirious or completely non-responsive. Thankfully, again, now that we've had several years of experience with various CAR-Ts in clinical trials, it's not so common in myeloma. Most of the neurological side effects seems to be grade 1 and 2. But the important point is that you have to be doing this at an expert center where they have experienced this quite a bit and they have a robust CAR-T program. So CAR-T cells are right now only approved for patients who have at least 4 relapses, and they have to have exposure or relapse after 3 classes of drugs. So you have at least experienced Revlimid, bortezomib or Velcade, and daratumumab, all 3, and had progressed on those. There are a couple of other new drugs that, in my opinion, are highly promising. One is called talquetamab. This is again the double Velcro approach, where the target, though, on the myeloma side is something called GPRC5D. So it's not the BCMA that we just heard about. So the importance of having new targets is that you can relapse even after the BCMA targeted drugs. So you need something that targets something different on the myeloma cells. Eventually, when we cure patients with myeloma, it will be because we have several drugs that target the myeloma from multiple angles. So it's like it's a battle. And if you just have the Marines, you cannot win the battle. You have to have the Marines, you have to have the Navy, you have to have the Air Force, you have to have the infantry, you have to have everybody. So essentially, the more troops we muster of different groups, the more effective our approach against myeloma is going to be. The myeloma cell finds out ways of outsmarting one treatment, we go after it with a different type of treatment. So this GPRC5D has literally in clinical trials, in my experience, saved people's lives so many times. So another agent is called the cevostamab. It's also a double Velcro approach that I like. Here the target is something called FcRH5. So this is my summary slide. So how we approach treatment depends on what drugs are available. So what is available as approved? Are you going to be able to get paid? Is it available as a clinical trial, or should the person join a clinical trial? Then the characteristics of the tumor. Do they have high-risk cytogenetic abnormalities? How long did the disease stay in remission before it relapsed? So primary refractory disease, where there is no remission and just relapse, that's actually worse than people who stayed in remission for 10 years and then relapsed. Do they have extramedullary disease? That's disease that's outside of the bone marrow, our bone, and in organs. How rapid is the relapse? Is it exploding relapse, or is it just like a slow relapse? Sometimes you can just observe a person with slow relapse. How is the patient frail? Are they able to get out of bed and do their stuff? How old are the patient? What are their comorbidities? Do they have, if they already have neuropathy, we would avoid a drug that causes neuropathy. If they have heart failure, we avoid drugs that can cause heart failure. What are their preferences about treatment? And then one of the big factors is the time from prior therapy and the response to prior therapy, and what drugs the patient may be refractory to. And that's also important. And finally, the overall approach is to do first relapse treatment is to do one of the triplet combinations that we talked about at the beginning, either a monoclonal antibody IMiD dexamethasone or a monoclonal antibody proteasome inhibitor dexamethasone. And later relapse, the importance of clinical trials and BCMA targeted agents cannot be overemphasized. So in summary, there are a lot of choices, and always have an expert in your corner. Always think about clinical trials. So this is, again, this will be in your slide set, and, this is just a little for you to look at later. Thanks, Kate.
Succinct presentation about what's going on out there, and hopefulness, I guess, would be another word. I remember working with you before that there was hope, but it was hope for a succinct amount of time. And today that hope is a longer amount of time because of efforts of both yourself and Dr. Cole. Now, I want to go over the audience Q&A with panel. We didn't get any questions this time, but you can also go over there to where it mirrors it pink. Is that where the box is for filling out, answering questions about the survey? A question mark is, okay. So just take a look at that. And I also wanted to do a shout out to several support group leaders out in that area. Kevin from the Minneapolis support group, you did a lot of help for me, and I appreciate it. And Mary, you're in Michigan, I believe. I could be wrong, but thank you so much. Couldn't do these things without the excellent work that's done by support groups across this country. 20 years ago, I started. There were 2. There's over 145 support groups in America alone. So you got answers out there. You can join on the Zoom calls. Just introduce yourself to the leader. There's cross-pollination going on right now, and it's really something, so take advantage of that. So without further ado, another dear friend of mine, Teresa, is going to speak about supportive care. And what we'll do is if we get some questions, then we'll try to handle some online, and then we'll do them towards the end of her presentation. So take it away, Teresa, and thank you, Dr. Hari.
Yes, thank you, Dr. Hari, and thank you, Kelly, Dr. Cole, the IMF for letting me be a part of today's workshop. And I am looking at the participant box, and I see a lot of familiar names. Some people that I know have been on this journey for many, many years, and actually some people that I know, having talked to them in the last week or two, are very new to this journey. And with that in mind, knowing that we have some people here from the Minneapolis group who are very embedded within the myeloma community, I just wanted to take 30 seconds of my presentation time to recognize and to celebrate a true trailblazer in the myeloma advocacy space. For those of you in the Minneapolis group and in the Minnesota region, Patricia Harwood has been a mainstay and, like I said, a trailblazer in the myeloma community. She started the myeloma support groups in Minnesota and has been a key person in really getting the word out and getting advocacy for myeloma patients. And so I just wanted to recognize Patricia Harwood, and those of you in the Minneapolis group will know what I'm talking about. So with that and the idea of being your own advocate, the focus of my conversation today, and I do want it to be a conversation, so please do enter your questions in the chat box or at the end when we have some time together. But talking about the idea of how to really navigate this journey. For those of you who have been listening that are sort of new to this community, a lot of good information has been shared, excellent presentations, but I can only imagine how overwhelmed that you are with all of the information. And so that's why it's so important to be participating in these types of activities, because you really want to better understand what it is that you need to know. And you can't understand all of it at once. You get bits and pieces as you go. And so understanding, moving forward, and working with your care team to better understand this journey. And when I think about your care team, really, it takes an entire crew, a village of people to be successful at this journey, you being the center of that journey. But can you imagine going to your primary care doctor and saying, "Hey doc, I think my myeloma is progressing. What do you want to do with that?" It's so important to fully understand who it is that you go to with your particular issues or complaints or needs. So obviously, I don't think there's anybody that go to their primary care and talk about, what to do next with my myeloma therapy. You would go to a myeloma specialist, or maybe you work with a general hematology oncologist. As Dr. Hari had mentioned, at different phases of your care, it may be most important to meet with a true myeloma specialist. As Dr. Cole had mentioned, myeloma is only 2% of all cancers, the second most common blood-based disorder. So if you imagine your general hem-onc doctor who is providing care to breast cancer, colon cancer, lung cancer, all of these high volume cancers, that's probably where their attention is going to be most focused. Not to say that they can't provide you with good care, but periodically it is important to get a second opinion or touch base with myeloma specialists, especially as the myeloma space is changing so rapidly. You need to know who to contact when it comes to certain issues. Maybe you have diabetes and now on dexamethasone as part of your therapy, your blood sugars are not quite as easy to manage. And so maybe you work with an endocrinologist or a diabetes specialist. Maybe you have bone-related issues from your myeloma, as Dr. Cole had mentioned, as part of CRAB criteria. And so maybe you work with an orthopedist. It's just really very important to understand who are members of your care team. That includes your pharmacists, your family and support network, like support groups, your clergy. All of these people are part of your overall care team, and you need to know who to go to. You are central to this, and so it's always important that you act as the connector of all these sites or of all these teams. And as I mentioned, there's a lot of information that's been presented on all of these new therapies, existing therapies, and how do you come to a treatment decision? Well, part of that comes from understanding what the options are. We know that there's a lot of research that's being done. We know that there's clinical experience. If you're at a center that may have greater access to some of these therapies, like CAR T or stem cell transplant, that may be a factor or a potential option. You have your own preferences, and as you learn more and more about different therapies, we have to really focus on what it is that's important to you, aspects of quality of life, to ultimately come to that treatment decision making. And so I want to talk a little bit about, how do you do this? How do you become part of your decision making? Well, knowledge is power. And so when you're meeting with your physician, it's so important to have an open dialogue, to have a conversation and feel comfortable expressing what's important to you as far as quality of life priorities. For some people, maybe they're retired and the time consumption for being at a medical center receiving an IV therapy is not a hardship. But for those who are still working, maybe it's very challenging for them to get time off of work. Maybe you're a farmer and being away in the summer for a stem cell transplant is just not possible, but maybe winter is a better time to do a stem cell transplant. It is so important to have those things in mind when you are talking with your care provider, your myeloma specialist or hemonc professional, when coming up with treatment decisions. So as you prepare for your visits, as you prepare to meet with your doctor or your nurse practitioner, whoever it is that you receive your care from, because it really is a holistic team, it's so important to be prepared with questions. What are your priorities? And putting those priority questions at the top of the list. You can even send those for many institutions through the patient portal or through online messaging to your care team. Make sure that you have a current list of your medications, and not just the ones that they've prescribed, but maybe other care providers have prescribed for you, and that includes supplements. Many people are taking supplements and may think that they aren't a medicine, but quite honestly, they are a chemical and they can interact with your other therapies. So it's important to have your care team know what all you are taking. What's happened since the last visit? Give them updates, good, bad, or otherwise. Whether it be job change, insurance change, new symptoms, or improvement in your symptoms. These are all important things as they look at your medications and they look at moving forward with your care. When you're actually meeting with your provider, feel confident, feel comfortable to speak up. Even if you have a question that you really can't fully formulate, they can help you, even if they have some inkling of what it is that you are trying to say or trying to understand. It's so important that you understand what your overall treatment plan is. Know who to contact after the visit if things come up, whether it be new symptoms or change in how you're doing. And I really do believe it's important to bring a caregiver with you. Having another set of ears, somebody who can take notes for you. And even if there are other people that want to be present, I know in our current era of COVID that there's limitations on how many people you can have with you, people can still be present by phone. I very frequently will tell people, maybe you're bringing your spouse with you, but one of your kids or a close person wants to be part of that visit and you're okay with it, dial up the phone when the provider gets in the room and have them be a part of the visit as needed by phone. So once you get home, you need to process all of the information that's been provided. And sometimes you need to share that information with other members of that care team, whether it be your pharmacist, your local hemonc doctor, if you've just seen a myeloma specialist, or maybe you need to do it with your primary care. Maybe the dexamethasone dose has been decreased and now there may need to be some insulin adjustments that are made. It's important that when you're looking at all of these different medications, that dose adjustments of your medications are fully communicated with all care team members, even when you're making your own dose adjustments. And I know you do it. I know you do it. And we'll talk about steroids, but dexamethasone is one of those drugs that so frequently is self-adjusted. And so it's so important that you're talking with your care providers about that. So it's important as you wander through this journey that you are working with the entire care team. And the IMF really does help people to fully understand this, to help you prepare for these visits. And they have many tools to do that. You'll see that on their website. And I don't want you to go to the website right now because I want you to keep listening to the information that's being provided. But use the tools that have been made available for you. And they've been made available because there has been a need, and the IMF has responded to that need. And so as you prepare for your visits with your healthcare providers, use the tools that are available. Now I'm going to shift gears just a little bit with some of the things that you may want to be talking with your healthcare providers about. And it's about how you feel, the physical aspects, the emotional aspects of this journey. We know that just the diagnosis of myeloma has overwhelming implications physically, emotionally, and even financially. We know that myeloma itself, from that CRAB criteria, causes symptoms. We know that the treatment can also cause symptoms, and sometimes these things overlap. It's really all about how you feel and how you are doing on this journey. And if your care providers don't know how you're doing, it's hard for them to help you. We know that if the symptoms are not being well managed, that may result in you not continuing therapy, and therapy that is keeping myeloma so well managed. If you're missing doses, if the dexamethasone is just too much for you or for your spouse, that it can cause challenges in how we're treating myeloma. So talk with your providers. Keep a diary of your symptoms. Write down how you're feeling. And you may even notice there's a pattern of how you're doing. Maybe you're not sleeping well. Maybe you're sleeping too much. Fatigue is a significant issue. It's actually one of the number one issues or symptoms that patients will express as affecting their quality of life. There may be some things that we can do about that, whether it be adjusting the timing of your medication. Maybe there's some things that are not even myeloma related that are impacting your energy level. But again, your providers are unable to help you unless they know about it. Even if you've brought it up repeatedly, if you bring it up again, it may be the point when it is heard, and be persistent. As I mentioned, I was going to talk about steroids. The doctors have talked about so many of the key elements of treatment, but steroids, dexamethasone, prednisone, tend to be a mainstay within the myeloma community, especially at time of newly being diagnosed and starting therapy, or at time of relapse when we are trying to get better control over the myeloma. We know that steroids have side effects, but we also know that they are very effective in creating a synergy with the other treatments, the other therapies that are there to provide control over the myeloma and to kill those myeloma cells. And so I think it's important for people to be aware of the fact that some of the things that you're feeling, and not only for you, but your spouses, your caregivers, to understand that some of these symptoms, the irritability, the difficulty with sleep, the mood swings that people can have, are associated with steroids. It's not that the myeloma has taken over this person. It can be the treatment that's doing it. We know that there is a risk of causing blood sugars to go high for people who are already diabetic or borderline, or even for people who are not. We know that there can be weight gain as a result of that seafood diet that people have. You see food, you must eat it. And so that can be disturbing to people. There can be hair loss or hair thinning more so with this. It's an interesting thing with the current myeloma therapies other than transplant. For most people, they may have some hair thinning, but they don't have complete hair loss, which then gives the opportunity or the option for people to choose to share with others, whether they're undergoing treatment or not. But with steroids, people can experience some degree of hair thinning. That's not uncommon. If you haven't experienced menopausal symptoms, steroids can help you do that with flushing and sweating that can happen. There's some things that you can do to work with those side effects. We know that it can irritate the belly, so please do take it with food, which is not too hard to do with steroids because you do have that seafood diet approach, but it can upset the stomach. And so using an over-the-counter prescription belly protector like omeprazole, pantoprazole, some of those therapies can help. We know that for most people, they're recommended to take it right away in the morning with breakfast when they get up. But quite honestly, for some people, I found that it works even better if they take it right before they go to bed. They may wake up earlier in the day, but they oftentimes are then tired by the time they get to bed the next night. There's usually at least one night in there that people's sleep is really significantly disturbed. But talk with your providers about ways of adjusting the timing of the medication if needed. But please, if you're even considering changing dosing, you really need to talk with your care providers about it. We very commonly will do some dose adjustments, but they need to be in the loop when you're having that conversation. Some topics that are not always discussed, depression and anxiety. I talked a little bit about fatigue as being the number one symptom that patients will experience, but there are many patients that will have issues with depression and anxiety. And why not? You've just been faced with a new diagnosis, as repeatedly has been said, incurable. Doesn't mean that it's not manageable, but it is life-changing and very overwhelming. It's overwhelming at the time of new diagnosis. It's overwhelming as you are trying to manage all of the medical appointments and the billing that goes with all of that. And it's overwhelming at pivotal times when you're making treatment decisions. So how do you work with the anxiety and the depression? Well, there's obviously medications that can be used, and getting help from a mental health professional. I think knowledge is huge, that in helping people to have a sense of control over their care, being able to understand the care that they're receiving. There are other things that people can do. Exercise, walking can help get those little endorphins running around in your head to help with the depression and the anxiety. Being a part of support groups. I facilitate a support group, which is now virtual, and I have quite a bandwidth of people that participate from all over the country. Got my North Dakota contingency. Hey, everybody up there. I've got people that join me from Atlanta, from Washington, D.C., really all across the country. And so I encourage people to participate in the groups. There are a lot of research that show that support group participation actually leads to improved survival. Relying on your sense of prayer, meditation, spiritual support is huge during this time. It does take a wide variety of approaches to manage depression and anxiety. Mindfulness, deep breathing, relaxation breathing. So these are all some things that can be done. And talk to your care providers about it, especially if you have any thoughts of self-harm. There are some of the medications that we use for neuropathy that have been implicated in worsening depression to the point of suicidal concern. And so really, you need to talk to your care providers if your symptoms are not well managed, including anxiety and depression. Something that's been big in our communities now for a year and a half is not new in the myeloma community, and that's the concern about infection. The precautions that have been recommended for COVID have been part of my world for the last 30 years in transplant. Good hand washing, watching for any signs of infection, wearing a mask. We do know that there is concern that the vaccines for COVID have not fully provided the coverage for immunity that we would like in our myeloma community. And unless you know for sure that you've mounted a full immune response, many people would recommend that you continue to wear a mask for self-protection, and having those around you be your insulator or your line of protection, so that if they are vaccinated, they're less likely to bring the infection home to you. We don't recommend any live vaccines, and so thankfully the COVID vaccines are not live. And even if you are not able to fully mount an immune response, we would still recommend that you get the vaccine, because some protection is better than none. We know that people will have a compromised immune function, not only from the treatment, but actually from myeloma. And so before you're diagnosed, many people will have said, I had pneumonia and I coughed so hard I broke a rib. I had shingles. And that's because the immune system is compromised by these myeloma cells, causing ineffective immune function. It's so important that if you experience fever, that you talk to your providers about it, whether it be at time of new diagnosis or any time along the trajectory of this disease process, especially during the course of stem cell transplant. Matter of fact, there's a study that was presented, I think it was 2017 ASH, that showed by using preventative antibiotics during the first 12 weeks of diagnosis of myeloma, reduced the risk of significant infection. And so we do know that myeloma in itself can cause compromise to the immune function, as well as the treatment that is being provided to control the myeloma. Another area that is of considerable effect on people's quality of life is pain. And we know that about 60% of people are diagnosed as a result of a fracture, spontaneous pathologic fracture at the time of diagnosis as a result of the bone disease that people experience with myeloma. We know that pain can come from other sources as well, like neuropathy. People who have had certain therapies like bortezomib or thalidomide, that they can experience peripheral neuropathy that can either be numbing or quite painful. And then there are those nagging, persistent medical procedures. Even blood draws after a while become an irritant, painful. Bone marrow biopsies, or maybe it's a surgical intervention to fix a fractured bone. All of these things contribute to pain and contribute to a decrease in people's quality of life. It's in the top 3 of symptoms that patients report most commonly. So there are things that we can do. One, we always like to prevent pain, and that can be from using an antiviral therapy so that it prevents the risk of shingles from happening, using bone strengthening agents so that we can reduce skeletal events, and even using sedation or other things for standard procedures. At Mayo Clinic, I'd say at least 80% of people who undergo a bone marrow biopsy will do it as a sedated procedure. You wake up in a nice warm blanket, all cozy, and the procedure is done before you know it. There are medications that can be used for pain, neuroleptic medications like gabapentin, pregabalin, a variety of things for neuropathy pain, analgesic or narcotics, as well as non-narcotics that can be used for bone pain and other pain-related issues. We strongly, strongly discourage people from using ibuprofen and drugs such as that, these non-steroidal anti-inflammatory drugs, because of the impact it can have on your kidneys. So we really want to reduce any additional impact that patients may have on renal function. Radiation therapy is commonly used in certain aspects of bone-related disease. If there is concern for a pending fracture because of myeloma disease within a bone, or concern for spinal stability, radiation can be used to treat a localized area of myeloma involvement, and that radiation can also help with pain relief. Things like vertebral compression fractures. There's a procedure called kyphoplasty or vertebroplasty that helps to stabilize that vertebrae or that bone in your spine and reduce your pain. There are some complementary and alternative therapies, but again, wanting to make sure that you are discussing anything that you take with your providers. Acupuncture, massage, even those things need to be discussed, because if you have a fair amount of bone disease, you need to talk to your providers about whether massage is a good recommendation. So with all of that, I want you to know that knowledge is power. The IMF has so many resources, from pamphlets that they will mail to you at your request. There are a variety of things, from different drugs to side effect management and things to watch for as far as side effects go. On their website, they have a variety of videos, short and long videos, 7-8 minute blurbs of really good information. There are a lot of discussion points about the bispecific therapies, the CAR T therapies, these immune therapies. Dr. Joe McHale has an excellent video out there on describing the variety of these in terms that are so easy to understand. Even Kelly would understand them. And so I encourage you to go to this website to learn more about the resources that are available. Again, knowledge is power. It's so important for you to be up to speed on what's going on in the myeloma community. Not that you need to make these decisions alone, but to be a part of that decision-making process. Feel empowered to be part of that decision-making process. And the only way you're going to do that is to understand, to learn more, and to be engaged with your healthcare. So with that, Kelly, I again want to thank you and the IMF for letting me be a part of this. I think I kept on time. I'm not sure.
You were very good with time, as well as Dr. Hari and Craig. But I have a couple questions on here. Do you see the questions over there, Teresa?
I do see them. There are quite a few of them.
Why don't we start with 46, where it says, is there information about side effects while in remission? You feel comfortable answering that?
I do. What is it? Side effects in remission? I've had doctors say that if you are in remission, you are back to normal. Well, I will tell you that having a complete response or being in a state where the myeloma isn't truly active does not stop a person from, one, continuing on therapy, as discussed in some of the previous slides. Even when a person reaches a state of being MRD negative, there isn't good consensus yet on how long a person should be on therapy. And so we don't know completely when to stop therapy. We have some guidelines, but people can still be having a good response but not receiving treatment, but still be receiving treatment. And even when people have stopped receiving treatment, and I saw this all the time as people had received 4 to 6 cycles of Velcade Revdex, they were off therapy for about a month as they come into stem cell transplant. And now, for the first time, their neuropathy is starting to emerge. And so side effects can come on after you've stopped a therapy. They can be persistent after you're off therapy. And if you continue on therapy, of course, they can continue to emerge. And so normal, what is normal? I think once you've received this diagnosis, life is never the way it used to be, because it's never gone. It's always going to be a part of your life. But it's a new normal. And the idea of doing whatever we can to improve your symptoms, to improve your quality of life.
Okay, and there's one other one, and I think you touched upon it, but as a caregiver, some people are asking, how do I best support my loved one? And some things come to mind with me, but I want you to say it. I have a really good marriage now. It's being supported, things like that.
Well, there are a few things that come to my mind on this. And the number one thing is the best way to support your loved one is to make sure that you're taking good care of yourself. It's kind of like that old adage on the plane. You put the oxygen on yourself before you help someone else, because if your tank is not full, you're not going to be able to help your loved one. But how do you best support that person? That's an individual answer, and you really have to have honest conversations, not only with your care team, but with your loved one. The way that I would support my loved one, whose birthday happens to be today, and he let me do this anyhow, is going to be very different than how I would want him to support me. And so it's really, and I do think it has to be more than just one person. It's too much, because that caregiver, that loved one, is going through this myeloma journey also, and they need support as well. And I know that Dr. Cole feels strongly about this. We've had conversations about this, the idea of that caregiver support. You have to take care of yourself first. And this is a marathon. This is not a sprint. This isn't going to go away very quickly.
Sure.
Take care of yourself as well.
Excellent answer. Craig, do you see what is a good antibody test result for MM patients? Do you see that question? I guess number 48.
Yeah, I'm not quite sure which antibody that refers
and is
to.
that, I'm wondering if that has to do with the COVID vaccine and the spike test.
All right. Well,
I can take care of that.
go ahead, Dr. Hari.
Yeah, so it depends on what drugs the patient is on. So most people on Revlimid maintenance in a remission, they usually have 100% of those patients have had antibody responses in a recent study that just came out a couple of days ago. Patients who are on Darzalex-based combinations, it's about 50 to 60% that have good responses. And there is no absolute titer at which a defined benefit can be. So most of the antibody tests, if it's above 100, I think the one that they're referring to here is the one where it's 150 for a detectable response, and some people are in the thousands. So if you get to even 150, it's a reasonable in that particular test. But there are many, many tests. There's, our institution used to do a test where even 1.8 was considered normal. So to some extent, it depends on the test. But you have to realize that even if you don't have a good antibody response, you may have a T cell response, which may be sufficient to prevent COVID. So I would say go ahead and get vaccinated. If you've not gotten an antibody response, you should probably, if a third dose becomes available, that probably is one thing to take. But again, don't despair if you don't have an antibody response. Keep masking, use the social distancing, all that. But also assume that you may have generated some protection.
I did notice. Go ahead, Craig. I'm sorry.
Oh, and we definitely, recommend that our patients and their loved ones surround themselves by people that have been vaccinated. And so, talking to your neighbors, talking to your friends and family about getting vaccinated, because that's the real safe way is to have everyone around you vaccinated, so they have that herd immunity.
Yeah.
That's a good point. I think that's a good point to all of our attendees as well. Well, I just want to take a quick minute here to thank all three of you for doing an awesome job today. As you guys know, I've done 100, and this is my 110th one. And I swear, I promise, I keep learning something more at each one. That makes me say, go, and I work for the foundation, but how much y'all are contributing to our foundation for questions and answers goes beyond any type of program I've ever worked with in my life. Thank you, thank you, thank you.
Thank you.
All righty.
And thank you to all the participants. I really am proud of you for joining and, not only registering, but actually attending and being a part of this. It's so important for your overall success.
Oh, it's thrilling. It's just thrilling. All right, I'm going to go on to some other things. Big round of applause from everyone that's here for all three of you, and I will talk to you three soon.
Bye.
Thank you.
Thank you.
You're welcome. All right. So now the video workshop, as I mentioned earlier, is on replay and with the slide. So if I'm not mistaken, they can pause the slide, take notes, pause the slide, take notes. And sometimes you'll have questions for those. So just be aware that that's out there for you. And it will be provided shortly after this is over, probably no later than tomorrow, Sunday. So you can do this with your family and review. Let's go to the next slide. Something that's so important to me is the feedback. I have to know what's going on. Last time we had, out of all the people, we had 75% feedback. That was phenomenal. I'd like to get that again, if not more. And your feedback helps us guide the program. So we don't get stale in our presentations, that we get you up to date. We get your family involved. We get your caregivers involved, and so forth and so on. So do take a minute after this. The next slide. Okay, here it comes. The sponsors: Amgen, Bristol Myers Squibb, GSK, Janssen, Karyopharm, Oncopeptides, Takeda Oncology. Wow. That's it. Y'all go have a great Saturday and have some fun and do what you do to have fun. Thank you so much, everyone.
Thank you. Have a great day.
Thank you.
Bye-bye.